Hello everyone, starting our today's class. First of all, you have to stay mute. Remember to mute yourself because there are a lot of different kind of sounds I hear during classes. Those gets recorded and that feels bad. Anyway, see, the Bangla class and the English class are the same. The same things described same way. All the important things are described, so you do any one of the class you feel comfortable. Okay, now first of all what we do, we will see some important structure so that we can remember better. First I will show you all the important structures, then we will go to our notes and I will tell you what to study and what not to study, because there are a lot of things. This is an ocean of knowledge. Now, guys, if you start studying everything, you will get lost. Like, what did I do when we were a child? When we were a child, we would uh, write the importance of having a goal. Like, a man without a goal is a ship without a rudder. Like this, uh, those old age old good old days. Okay, guys, so a man without a goal is like a ship without a rudder. Who I'm your rudder. I will tell you where to go, where to study, where you will fall, what to focus on. Other than that, you will need nothing, simply nothing, nothing extra you will need to pass this exam. This is a very easy exam if you take the right steps. Okay, now I will be showing you. I will not talk a lot because I will tell you only the important things. A lot of things you should just avoid for your sanity, for your mental health, for your good life. Now what do? You watch the class, then after the class I will be available in our question posting group. You post your questions, not a problem, I will reply you. See, and this is the uh, I will tell you a lot of things. Like, this is the first class. Okay, there are a lot of things connected to head neck surgery too. We will have surgery section too, so you might want to wait to complete the whole course. You will get a lot of answers later on, but I will tell you everything during classes. When you are studying neuroanatomy, only study neuroanatomy. Forget everything. Forget every single thing. Then, when you go to head neck, only study head neck. Study like this is the last time you are studying neuroanatomy. Study like this is the last time you are studying neuroanatomy. We will complete the course within 2 months, then we will start revising. So you will not forget. Trust me, you will not forget. I will not let you forget. Okay, so first of all, we will see the skull. What do we see? We will see the foramen inside the skull. So this is our sphenoid bone. Okay, this is our sphenoid bone, and the thing you see, this is our lesser wing of sphenoid. This is our greater wing of sphenoid. Why am I telling it? Because there is a very important thing. Just see what I show you. There is a very important thing that is at the side of our skull. At the side of our skull. This H-shaped area. This H-shaped area, this is called pterion. Okay, this is called pterion. P T E R I O N. Now T is silent. T is silent. Just like I am in Spain, I am in Spain, but the S is silent. So I'm just in pain. I'm not in Spain. Anyway, so Tyrion, they ask you, this is a very important structure. Why? Because this is a very thin structure, and behind it, we have a very, very important artery that is called your MMA, middle meningeal artery. This middle meningeal artery is a branch of maxillary artery, which is a branch of external carotid artery. Okay, we will show you that. I will show you that. Don't worry. So just, just behind, just inside this area, we have that structure, and they ask you what are the bones that it is made of. It is made of greater wing of sphenoid, squamous part of temporal bone, frontal bone, and parietal bone. These four bones makes up this area. So they will ask you this question, and let me show you the artery. Guys, I told you you have to stay mute. Okay, please. So this is C. You can see this artery, right? We just hide it. And what we do, we add another layer of the artery. Guys, please stay mute. Please stay mute. Because if I get out of this app may create problems, and I will have, so I can't go out of it. Now, first, I will show you the artery. See, guys, see with your both eyes open, wide open, with your pupil dilated, with your sympathetic system activated. Guys, see, this is that much important. This is our middle meningeal artery. This is our middle meningeal artery, and these are the branches of middle meningeal artery. They don't ask you about the branch. And see the foramen it's entering. See the foramen. This remembering this artery is a pain, just like Spain, but S is silent. And this foramen is called foramen spinosum. Foramen spinosum. So middle meningeal, oh, everything about middle meningeal artery is important. So number one thing, what's the foramen? It enters the skull. Foramen spinosum. Spinosum. I will tell you common scenario they give you about it. Then they will ask you that a man is hit by side of head with a baseball bat or with something, and after that he has an extradural hematoma. Anytime they mention side of head in MRCS part A, it's always middle meningeal artery. And they will ask you what's the origin of this artery. Remember, maxillary artery, which is a branch of external carotid artery. External carotid. We have all of these in our notes. Don't worry, just see now. Okay, so this is our first and most important foramen, first and most important artery. That is our middle meningeal artery. See this? See this? This is very complicated thing. This has become very complicated with all the arteries, right? Let me make it simple for you. Let me make it simpler. Okay, then I will show you all the foramens, which are very, very important, guys. Very, very important for your exam. So second thing I want to show you is internal carotid artery. This is our internal carotid artery. See very clearly, this is our internal carotid artery. And remember, internal carotid artery enters the skull through carotid canal. And this empty area is foramen lacerum. And this is a very important question too. See, I will tell you about the foramens. Foramens are very hard to remember. I know, but I will make it simple. When I go to our notes, you will see you know everything. So watch this first. So remember, carotid, internal carotid artery enters to carotid canal. Now, after entering through carotid canal, it will go above a foramen that is called foramen lacerum. So foramen lacerum does not contain, mark my word, does not contain internal carotid artery. Internal carotid artery is just above foramen lacerum. Okay, this is not a content of foramen lacerum. You get confused with it. So don't get confused. Now, after entering the skull, internal carotid artery will continue as middle cerebral artery, middle cerebral artery, and give a branch as anterior cerebral artery. Now, two anterior cerebral artery will be connected with anterior communicating artery. Let me show you. Let me rotate the skull. See this beautiful image. See two anterior cerebral arteries and continuation is middle cerebral artery. Middle cerebral artery is a continuation of internal carotid artery, not a branch. The branch is external anterior cerebral artery, which is connected with anterior communicating artery. Now, see, this is the anterior circulation of brain. Anterior circulation of brain. Just see what I show you, you will have everything. Now we have a posterior circulation too. What is a posterior circulation? That comes from behind. Comes from behind. How it comes from behind? See this beautiful artery. This is our vertebral artery. So from two sides, vertebral artery will come, and this is, just see. I will tell you everything in head neck too. Just see now. Okay, guys, this will help. Arey, what's wrong with you? Okay. Now, see, this is our vertebral artery that comes from our subclavian artery and enters our foramen transversarium with cervical 6. Cervical 7 has a foramen transversarium too, but it does not transmit vertebral artery. Remember this point. Again, C7 is the most prominent vertebra because of its big spinous process. See how big it is. Big spinous process. Big spinous process. And you can locate it in any subject or any patient. You can locate it by telling him to making his chin down. All of the informations I'm telling you is important. They ask you in question. Now, then vertebral artery will go upwards through foramen transversarium and then cross against posterior arch of the atlas. See, then cross around the posterior arch of the atlas and enter the skull. Enter the skull through, oh my god, enter the skull where in front of, here we have midbrain, pons, medulla. So in front of medulla, up to here we have medulla. In front of medulla, it will pass upwards, forwards, and medially and connect at the base of pons to form basilar artery. So this is our posterior circulation. Two vertebral artery making basilar artery. This basilar artery will give posterior cerebral artery, posterior cerebral artery. And now the question is, anterior circulation and posterior circulation is connected with posterior communicating artery. This is very important. That's why this is the first thing I show in neuroanatomy classes. And we have studied it from our childhood, the circle of Willis. So this is the circle of Willis, which is, so see, a lot of things you know from before, a lot of things. You just need to know what are the questions they ask. I will tell you the specific question, which artery connects anterior circulation and posterior circulation. Every question I tell you has a possibility to come in your exam. But before September exam, I cannot exactly tell you what will come in January. So learn the basics now. Then in revision classes, I will tell you exactly what are the things that are going to come in your January exam. Now, so these two circulations are connected with our what? Posterior communicating artery. Now I'm clearing my 2D pen. Let's add the brain. After I add the brain, you will get confused, but don't get confused. Remember the arteries I tell you. Other than that, no arteries are important. Oh ho 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 ho. Sorry guys. Corpus callosum. Let's hide it. Let's hide all these things. Hide, 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 hide. What you have to do, you have to do the class first. You have to do the class first. Otherwise, you will study a lot of unnecessary things and you will miss a lot of necessary things. And that will just give you false confidence before and after the exam, and you will get frustrated in your life more. So, I'm just helping you to alleviate your frustration. So, now let's see from side. Let's see from side. Remember this vertebral artery? This is our vertebral artery. This is our pons. In front of pons, we have basilar artery. And here we have posterior cerebral artery. Okay, I'm clearing it. Now, why did I add these things? To show you the foramens from all the cranial nerves. So, number one will be our olfactory. Okay, maybe not from this side. Let's just show you the foramens first. Okay, 1 minute, guys. I will show you later on. So, arteries are over. Later on, the other important arteries I will show you. Then nervous. We need nervous system to see all the foramens, what they transmit. These are the questions that are important. And from our chart, I will make it more simplified. Guys, I'm here. Don't worry. I didn't die. So stay with me. So from above, we are seeing all the nerves, all the 12 cranial nerves. I will show you and their foramens. They ask you questions. Where do they come out from the skull? They ask you this question specifically. So I have to show you these things. Otherwise, you will forget. So first thing is our olfactory nerve. Olfactory nerve will come through cribriform plate of ethmoid bone. This is our ethmoid bone, and this plate is our cribriform plate. From olfactory nerve, only these thing you need to know. Other than that, nothing else is important. Then we have optic. This is our optic chiasma. We all know it. Optic nerve goes through optic canal. Optic canal. Okay. Now then we have, see serially the way I show you, you will never forget. And from our notes we will be studying too, right? Then we have superior orbital fissure. Then we have superior orbital fissure. Now, superior orbital fissure, right now just see. 3, oculomotor nerve. Then we have 4, trochlear nerve. Then we have 6, abducens nerve. So serially, 3, 4, of course we have 5, but 5, 1. 5, 1, which is ophthalmic branch of trigeminal nerve with its 3 branches. What are the 3 branches? Frontal, nasociliary, and lacrimal. All 3 branches goes through superior orbital fissure. I know you find it very hard to remember, but don't worry. I will give you simple things. Now just see. Just see. Okay. Then we have trigeminal nerve second division. That is our maxillary division of trigeminal nerve. Remember when, what was the first like What was the first Apple phone I liked most? Like the 14 Pro Max. Okay. So this foramen is named foramen rotundum 14 Pro Max, which transmits maxillary division of trigeminal nerve. Foramen rotundum is our maxillary division of trigeminal nerve. Foramen rotundum that transmits our maxillary division of trigeminal nerve. Then we have our third division of trigeminal nerve, which is mandibular division of trigeminal nerve that comes through. This is our beautiful foramen, which I told you. See, remember the serial. This is our foramen rotundum. This is our foramen ovale, and this is our foramen spinosum. Okay. If you look from above, if you look from above, you will see that superior orbital fissure. Here we have superior orbital fissure. Then we have foramen rotundum. Then we have foramen ovale. Sorry, let me see it clearly. Okay. These are superior orbital fissure. Then we have foramen rotundum. Then we have foramen ovale. Now, what are the other things that goes through foramen ovale? Remember, otic ganglion, OVALE, otic ganglion, V3, mandibular division of trigeminal nerve. Then we have lesser petrosal nerve. Then we have emissary veins. Okay, we have it in our notes. Don't worry, I will be showing you later on. Then, then we have this thing. This is our facial nerve and vestibulocochlear nerve. Just remember that facial nerve and vestibulocochlear nerve stays together. They are friends and they stay together. They go through internal acoustic meatus and enters inner ear. Internal acoustic meatus. Internal acoustic meatus. This is our internal acoustic meatus in our petrous part of temporal bone. See, this is our petrous part of temporal bone. Petrous part of temporal bone having internal acoustic meatus. Then we have our jugular foramen. This jugular foramen transmits after 8, 7, 8 goes through internal acoustic meatus, and then jugular foramen will go through, I mean, 9, 10, 11. These three will go through our jugular foramen along with sigmoid sinus and internal jugular vein. Sigmoid sinus becoming internal jugular vein. So see this very carefully, you will remember it. And then we have hypoglossal nerve. See, then we have hypoglossal nerve having small hypoglossal canal. Okay, having small hypoglossal canal. This is our glossopharyngeal, vagus, and this is our accessory nerve. Glossopharyngeal, vagus, and accessory. These three. Let me show you the veins. This is our sigmoid sinus becoming C, internal jugular vein. Okay, this is our sigmoid sinus becoming internal jugular vein. And this is our sigmoid sinus. Okay, guys, then we have mastoid and we have this one. Then we have stylo. This is our styloid process and stylomastoid foramen, which transmits our facial nerve. So these are all about the foramens. Okay, these are all about the foramens. Now other things. Other things I'm going to show you is these are the all the important things you need to know. Other things not important. Then if this is the face, remember this is the face. We divide it into three parts. Okay. Above. Remember all the sensory supply will be given by trigeminal nerve. and above will be ophthalmic branch. Then we will have, this is our infraorbital foramen, and we will have, I will show you infraorbital nerve here from maxillary division. So here all the sensation, touch, pain, temperature will be provided by maxillary nerve, and after that all the touch, pain, temperature will be provided by mandibular division of trigeminal nerve. Okay, let me show you, because this is important. They will ask you questions. See, this is our frontal bone, and here is our supratrochlear nerve coming from ophthalmic division of trigeminal nerve. This one is our frontal nerve. So frontal, nasociliary, and lacrimal. Let me hide this eye. Then you can see it clearly. See, frontal. This is our frontal nerve, and from in front we can see this is our frontal nerve. Frontal. This is our lacrimal branch. This is our lacrimal branch going to lacrimal gland. Lacrimal branch going to lacrimal gland, and this is our nasociliary nerve. Nasociliary nerve giving infratrochlear nerve, not important, but this branch is important. Here we have anterior ethmoid branch, which is not seen here. They didn't give that. Here we have it, maybe this one. Okay, we don't have anterior ethmoidal nerve here. Let's hide it, and we can see it probably. This is our anterior ethmoidal nerve. The one in, let's hide this area and you can see it. This is our anterior ethmoidal nerve. Why is that important? I will tell you why is that important. Remember specific places. Remember specific places, I tell you. This tip of nose is supplied by anterior ethmoidal nerve. This is the tip of nose. This is the tip of nose. Let me show you. Let me add the skin a little bit. So, oh my God. Sorry. So this is the tip of nose is supplied by anterior ethmoidal nerve. Okay, anterior ethmoidal nerve. Then this is the ala of nose supplied by infraorbital branch of maxillary nerve. Remember what I said? Infraorbital nerve. Infraorbital nerve. Infraorbital will supply this area, these two area, ala of nose, and tip of nose is supplied by anterior ethmoidal nerve. And of course, with it, infraorbital nerve will also supply lower palpebral conjunctiva and lower eyelid. Okay. So what's the general rule? If you have pain in ala of nose, you will have pain in lower palpebral conjunctiva too, because these two are supplied by same nerve. So you will have a referred pain. Okay. Then this infraorbital nerve, then this infraorbital nerve will supply ala of nose, lower palpebral conjunctiva, and it will give superior alveolar nerve too. Superior alveolar, which is superior dental nerve, supplies maxilla and upper teeth. Supplies teeth, upper teeth. Superior alveolar nerve, and it will also give a labial branch which will supply only upper lip, this part. So up to this maxillary nerve branches, which is given by infraorbital nerve, all the things are given by infraorbital nerve. Then we have mandibular division of trigeminal nerve. So I will so this mandibular division of trigeminal nerve will supply from this area, lower area. Okay, lower area, this lower area. So how it will supply? Let me tell you how. Let's see from the side. Let me show you from the side. Remember, here we have our parotid gland. Okay, right now just forget it. So skin over parotid gland, touch, pain, temperature. is supplied by mandibular division of trigeminal nerve. Now, mandibular division will give two nerves. One is lingual nerve and another is inferior alveolar nerve. This inferior alveolar nerve will, I will show you, enter inside the mandible, and then come out through mental foramen here, which is called mental nerve. Again, inferior alveolar nerve is also called dental nerve, which supplies lower teeth. Lower teeth. Okay, inside mandible. I will show you dental nerve. And this dental becomes mental when it comes out through mental foramen. Okay, it's mental nerve. This mental nerve will give a labial branch and supply lower lip. Lower lip. Now, this mandibular division will not supply this area. This is the angle of jaw. This is the angle of jaw. Remember, this is the angle of mouth. Don't get confused. And this is the angle of jaw. This jaw is supplied by greater auricular nerve. Remember what do we do? In Bangla, we say, কেউ যদি বেশি কথাবার্তা বলে ওকে কানের নিচে লাগাইলে একটু বেশি জ্ঞান দিলে তাকে কানের নিচে লাগান সে ঠিক হয়ে যাবে সো কানের নিচে হচ্ছে জ্ঞান that means under your earlobe is জ্ঞান. That is greater auricular nerve. I will show you all these right now. Let me just fade it a little bit and we can see. Let me just fade it a little bit now. So this area, no, just hide it. We don't need it anymore. No, this area. So facial nerve, I will show you facial nerve. Okay, let's add the skin again. Let's show you some another thing. So this earlobe lower part is supplied by greater auricular nerve. Okay, this area, and these are specific questions they ask you in exam. Specific question: which nerve supplies angle of jaw? Greater auricular nerve. If someone has pain in wearing earring, which nerve is involved? Greater auricular nerve. Now, behind earlobe, posterior surface of the earlobe, posterior surface and behind earlobe are two different things. Behind earlobe over your mastoid area supplied by lesser occipital nerve. Lesser occipital nerve. But posterior surface of earlobe is supplied by again GAN, lower part, greater auricular nerve. And this area lesser occipital nerve. You will remember it all. Don't worry. When we have it all in our notes. Okay, don't worry. Now we have parotid gland on in front of our ear, and inside parotid gland, facial nerve will give anterior division, posterior division. Anterior division will give branches, posterior division will give branches. What are the branches? Let me show you, and you will remember it better. This is our anterior division. Gives. Let's add parotid gland too. No, digestive. See, this is our parotid gland. Inside parotid gland, if we cut it out, see, if we cut it out, we can see that inside we have facial nerve branching into superior division and inferior division of facial nerve. Now this superior division will give, but it will not supply parotid gland. It will just enter and divide. It will give 5 branches: temporal, zygomatic, buccal, marginal mandibular, cervical. We have it in all our notes. You don't have to make note or anything. Just take our book and point it out there. Don't worry about it. You will know it all. Now, then we hide parotid gland. Now we can see clearly. Now, what are the other things that passes through parotid gland is important. See, this is our retromandibular vein. Again, if we undo, we can see the parotid gland again. Okay, so let me just cut again a little bit. This area. Okay, so we can see inside parotid gland. What are the structure that are inside? They are important. Facial nerve will not supply parotid gland. Facial nerve will just enter. Let's add the arteries and we will see. See very carefully and you will know it all, guys. That's why arterial, venous, add some more veins. Okay. So remember the structures entering parotid gland. Just see the structures now. We have it all in our notes. They ask you question. What are the structures? So facial nerve enters parotid gland. Then we have the structure that is auriculotemporal nerve. That is inside parotid gland too. Then we have superficial temporal artery. Then we have superficial temporal vein. Okay, these two meets inside parotid gland. These two meets inside parotid gland and becomes our retromandibular vein. Okay, uh, are you seeing it clearly? Okay, guys, see, this is our superficial temporal vein and this is our maxillary vein. These two will unite and make retromandibular vein, and this is the most common vein to bleed during parotid surgery. Most common vessel to bleed. Then we have external carotid artery and its same superficial temporal artery. Let's hide it and we can see that it will give two branches, maxillary artery and superficial temporal artery. Maxillary artery, superficial temporal artery. Maxillary artery, again I am telling again, maxillary artery and superficial temporal artery. This maxillary artery will go inside and give. So maxillary artery is a branch of external carotid artery. Maxillary artery will go inside and give the first one I told you, middle meningeal artery. Let me show you at this side. This is our maxillary artery. I will be adding, and this is our otic ganglion, or pterygopalatine ganglion. I will tell you about that. Sorry, guys. So this is our maxillary artery. Watch with me. I'm adding the arteries and see. You will see this middle meningeal artery. This is our middle meningeal artery. This is a branch of maxillary artery coming from this area. See, this is our maxillary artery and this is our middle meningeal artery. So this is very complicated, but don't worry about it. Just remember the things I told you. Okay, and you will not get confused. Remember all the important things. Okay, then the things I'm showing are only the important things. Other things are not important. Now I'm going to show you what enters mandible. This is important. Why important? Veins, no, nerves. See, this is our mandible. And what did I tell you? I have to cut it out for that. Let's cut it. See. Now we can see inside mandible. Why we didn't add maybe. Guys, stay with me. Stay with me. No. Okay, guys, wait. Wait a little bit. I have to add more arteries. Okay. Oh, I forgot to show you one thing, that this is our parotid gland and this is our parotid duct, that is Stenson's duct, and it opens behind our upper third molar. See, it opens behind our upper third molar teeth. Third molar. Upper third molar. Name Stenson's duct. Okay, name Stenson's duct. Let's just hide this maxilla. So we cannot see, we have to add more nerves to see those. This is our inferior alveolar nerve, which I am trying to show you that. See, now I am getting a clear picture of it. See, this is entering the mandible. I was just trying to find this angle. Okay, this is our mandible and this is the foramen. Your inferior alveolar nerve will enter, and this is the lingual nerve which is on medial side of the mandible, which does not enter mandible, does not enter, but inferior alveolar nerve will enter mandible. So you have to remember this statement. This is a very important statement, and this is our mental foramen. This is our mental foramen, and inferior alveolar nerve will come out through this. Let me show you a this one. See, this is our inferior labial branch, and this is our mental nerve through mental foramen. This is our mental nerve through mental foramen, which is a sensory nerve and supply sensation of lower lip. Okay, so this is our infraorbital nerve. This is our infraorbital nerve, which is giving a nasal branch, and another is superior labial branch supplying our upper lip. Very, very important. These are specific questions they ask. These are one line questions they ask. Okay, so this is our infraorbital nerve supplying palpebral area of nose, superior labial branch, and then we have mental nerve supplying lower lip and this area. Touch, pain, temperature. Remember, touch, pain, temperature, and facial is motor. It will cause all your facial expression. It will give all of your facial expressions. Then let's just see our brain a little bit. Then we will go to our. Oh, we need to see the scalp a little bit and dural venous sinuses too. Okay, guys. So this is the layer of scalp. We all know. We all know that. What are the things? That is scalp. SCALP, skin. Then we have subcutaneous tissue. Then we have aponeurotic layer. Then we have loose connective tissue. Then we have P or pericranium. Let me. Okay. Skin, subcutaneous tissue, aponeurotic layer. Then we have L, loose areolar tissue. Then we have pericranium. Okay. Now, what is important here? Nothing much, just one question. Then we have brain layers. See, these are the just the basics. So just watch. You have a lot of time. 4 months is a lot of time. So this is our dura. This is our arachnoid matter. Arachne means spider. These are like spiders. So these are our arachnoid matter. And then we have pia matter. Pia matter, just like visceral layer of peritoneum, right? It just attached with the brain. These are just attached with the brain. Okay, so this is our arachnoid. This is our arachnoid matter, and see, inside it we have CSF, cerebrospinal fluids. So CSF is in arachnoid matter. Okay, CSF is in arachnoid matter. Then we have bridging veins, cerebral bridging veins, cerebral bridging veins. So the thing I'm trying to tell you that this is our dura, and behind dura we have bridging veins inside arachnoid matter. A. So subdural hemorrhage happens due to this bridging veins rupture, rupture or ছিঁড়ে যায় যেটাকে বলে. Okay, so these bridging veins causes, these bridging veins causes our subdural hemorrhage. Subdural hemorrhage. Now they ask you questions about hemorrhages. Okay, now this is our dura. Has two parts. You don't need that, just remember this is our dura. Okay, this is our dura, and this is our superior sagittal sinus. I will show you other sinuses too, other sinuses too. So All the blood vessels, CSF, cerebral arteries are situated in subarachnoid space. Okay. All the blood vessels, CSF. Remember, blood vessels, CSF are contained within subarachnoid space. Remember this point of information. And when we have scalp avulsion, this aponeurotic layer is gets avulsed. This layer. Okay. This gallia aponeurotica gets avulsed. Now you need to see some dural venous sinuses. Okay, you need to see those. This is very important. They ask you drain, they ask you drain of dural venous sinuses. This is very easy. I feel like this is very easy because I have studied it a lot of times. Maybe see, this is fox cerebri. This is fox cerebri. Fox cerebri is just a partition between two lobes of your brain, two parietal lobes of your brain. It divides two parietal lobes of your brain. So if we go close, you will see this is just a curtain like, this is a curtain like thing. So this is a free edge, and this free edge has two sides, has two sagittal sinuses. Let me show you. Superior sagittal sinus, and this free edge has inferior sagittal sinus. Simple as that. Superior sagittal sinus and inferior sagittal sinus. Then superior sagittal sinus comes down and inferior sagittal sinus meets straight sinus. This is our straight sinus and meets at confluence of the sinuses. Let me hide that. This is our straight sinus. So inferior sagittal sinus will drain into straight sinus. Guys, please mute yourself. Straight sinus, guys, inferior sagittal sinus drains into straight sinus, and superior sagittal sinus will drain into, and this is the confluence or meeting of sinuses. Here we have another structure that is called tentorium cerebelli. Tentorium cerebelli. This is just like a tent. That's why it's called tentorium cerebelli. Okay, we hide it, and we can see this big transverse sinus. Okay, we can see this big transverse sinus. So these three structures will meet here, and that's why it's called a conference of sinuses. Or I say conference, but it's just confluence of sinuses. Okay, because three sinuses are meeting: superior sagittal sinus, our uh, straight sinus, and transverse sinus. These three sinuses will meet here. So we get confluence of the sinuses, and here after that, before showing you, you can see it clearly that it's an S like structure, so there will be sigmoid sinus. Let me add. Oh my god. So they will go at last, they will go to sigmoid sinus. Okay, they will go to sigmoid sinus, and then they will go to internal jugular vein, and then they will go to, our beautiful heart. Okay, so you don't need that. Just remember this thing, which thing I told you. What did I tell you? That superior sagittal sinus will drain into, superior sagittal sinus will drain into transverse sinus and straight sinus, and all three will meet into confluence of sinuses. Okay, inferior sagittal sinus will drain into straight sinus. We have it in our notes. Don't worry, I will show you again, and you will remember it. So these are the dural venous sinuses. You need to know other things just a little bit more. Then we will go to our notes immediately. Don't worry. Just the brain. And where do we have which nerve in brain? Where we have which nerve? We are showing seeing from in front and from the foot end. Okay. So let me show you the important things. Do you need to know all the gyrations and sulcuses? No. Just the basic idea, you all have it. They will not ask you any question, just for your study purpose. We all know that this is frontal lobe, duro, and you just need to know one sulcus, that is central sulcus, because we are going to use this term a lot of times. These are central sulcus, okay, and these raised area are gyrus, simple as that. So these are pre-central gyrus, these are post-central gyrus. We will talk about that later on, primary motor area, all these things, you don't need that right now. Okay, and this is our temporal lobe, very simple. This is our temporal lobe, this is our parietal lobe. We all know these are temporal, these are parietal, temporal, parietal, these are occipital, simple, these are occipital. Now then we have brain stem, this is our medulla, this is our pons. Okay, other than that nothing you need to know. You just need to know some other things. Brainstem consists of midbrain, pons, medulla. We hide it. Now we are going to see all the nerves. So this is our optic chiasma. This is our optic chiasma, and see under it we have pituitary gland. Why? This is important. This is very important due to some reasons. I will show you why. Then we have pons. Let's add the nerves. You will be needing the nerves. So these are optic nerve. Then above pons, from midbrain, we have oculomotor nerve. From midbrain, we are having oculomotor nerve. Then at the side of pons, at the side of pons, at we have got trigeminal nerve. We have got trigeminal nerve. So olfactory, optic, oculomotor from midbrain, trigeminal from pons. Then we have pontomedullary junction. This is the pontomedullary junction, and they ask you what are the nerves that comes out through pontomedullary junction. Remember serially. Remember serially. Number one, most medial, abducent nerve. Then we have facial nerve. Then we have vestibulocochlear nerve. 6, 7, 8. Then at cerebellopontine angle. Then at cerebellopontine angle, we have this nerve. So at cerebellopontine angle, we have this facial nerve and vestibulocochlear nerve. Okay. But in pontomedullary junction, we have abducens nerve, facial nerve, vestibulocochlear nerve. Now, from sides of the medulla, we have the other nerves from medulla. From medulla. So from pontomedullary junction, we have 6, 7, 8. From cerebellopontine angle, 7, 8. From sides of the medulla, 9, 10, 11. From medulla, 9, 10, 11, and of course 12, hypoglossal nerve. Of course 12. Now, let me show you another thing. Very important. The arteries. See very carefully. See very carefully. Not all arteries you will need. Just remember these arteries. See, oculomotor nerve is very close to. Let me show you guys. Where is our oculomotor nerve? This one. We have to add more arteries. Sorry, guys. This is becoming very complicated. So, stay with me. This is our oculomotor nerve, and we have posterior cerebral artery. We have posterior cerebral artery just behind and around oculomotor nerve, and of course posterior communicating artery. So if there is an abnormal dilatation, there is an abnormal dilatation or any aneurysm in these two arteries. See, let's say an U-shaped area has been appeared, that is aneurysm in posterior communicating artery. Which nerve it will compress? Write me in the chat box. I will check after the class. If there is posterior cerebral artery aneurysm, it is dilated, which nerve it will compress? See, this is very beautiful, our oculomotor nerve. And what happens when oculomotor nerve compresses, I will tell you in our classes. I will tell you in our class. You will know everything, every single thing. You will enjoy the process, guys. You will enjoy the way I teach you. Then, so this is our posterior cerebral artery. These are posterior communicating artery, and oculomotor nerve is very close to these two. And any aneurysm or any burst or rupture will affect oculomotor nerve. And again, optic chiasma. Behind optic chiasma, we have pituitary gland. So any enlargement or tumor will compress optic chiasma above. Then this artery, this is our posterior inferior cerebellar artery. This is our posterior inferior cerebellar artery, or PICA. These are posterior inferior cerebellar artery. So this posterior inferior cerebellar artery, guys, see now, this is our anterior inferior cerebellar artery, and this is our posterior inferior cerebellar artery. Let me write it down just. This is our ICA, AICA, and this is our PICA, PI. What's happening? PICA. Okay. So this is our PICA. See, if we have an aneurysm or problem in our posterior anterior inferior cerebellar artery, AICA, see, 6, 7, 8, these three can be involved. And if PICA, if the problem is in PICA, see, all these nerves, 7, 8, 9, 10, all this can get involved. But remember the serial. Remember the serial. This serial is very important. This serial is very important. So these are the problems with AICA and PICA. You can get confused. Don't get confused later on. Just come back and watch this portion. See, this is our AICA. If we have an aneurysm here, our abducens nerve can get involved or injured. If we have an aneurysm here, that is PICA, then our facial vestibulocochlear, then we have our glossopharyngeal vagus. All these can be injured. Guys, these are the things we have to see. Then we will go to our notes and complete. So uh, one thing, that is, don't get worried about long lectures, because all you need to study is contained with it. Okay, you just watch this class and you will have only 1 to 2 hours to study it. Watch this class and you will need only 1 to 2 hours to study it. And I will be starting about our notes just 5 minutes later. Give me a break. I will come back within 5 minutes. Stay with me, don't go. Okay, guys, let's start our notes. Guys, see this thing when we first started, just once this question came, you can just give a reading, not important these days. Now, remember, now see, development of brain, you don't need to know. You don't need to know. They don't ask. Just remember that there was a tube, neural tube from embryology. Whatever I'm going to tell you over the course, only those will come. I will tell you only the things that will come in your exam. I will not give you extra burden, and you will miss me all your life after you complete the course and pass the exam. Okay, now this brain will develop three vesicles: prosencephalon, mesencephalon, and rhombencephalon. Now see this prosencephalon, see the one that's progressive, that goes forward, we call them progressive. So the first part or front part will be called prosencephalon. The middle part, middle mesen. Then the rear part, rear means behind, right? The rear part, those who have cars, they know the rear view mirror, or those have bikes, they know the rear view means the mirror you have to see what's behind you. So rear means behind. So R for rear, R for rhomben. So this is our hind brain or posterior brain. Now this prosencephalon, now this is progressive. And who was the most progressive woman I have seen in my life? You are going to London, everyone knows Lady Diana, right? She was progressive, and she took part in a running uh, event for Prince William. Why this is important? Because royal wives were not allowed to take part in public events. So she was very progressive. Why am I telling it? See, in her marriage, in her marriage, this photo went viral at that day. We didn't have Facebook back then, but this photo went viral. She was so tired. She was so tired. This Lady Diana or Princess Diana slept during the event, and all the cameras at that time was focused on her. We you can call it telescopes. So this forebrain is progressive, and the middle part of the brain which just sits and does not grow, that is called Diana or diencephalon, and around her telescope, telescope, which grows, that is called telencephalon. Simple as that. So we will have diencephalon and telencephalon from forebrain. What will they ask? They will just ask what are the structures that are developed from telencephalon, what are the structures that are developed from diencephalon. Okay, telencephalon, cerebrum, two cerebral hemispheres. Diencephalon from Diana. Remember at a wedding party, what do they people do? They take thala and eat, right? So they thalamus. Just remember thalamus. And we all know that around thalamus we have a lot of thalamuses too. So under thalamus we have subthalamus. Above thalamus we have epithalamus. So under thalamus we have hypothalamus. Okay. So all these things. So hypothalamus and epithalamus. Under the thalamus, hypothalamus, and we have epithalamus. Okay. Now, then it comes midbrain. Midbrain is midbrain. Nothing else comes from there. And from rear, we have posterior view, right? From posterior, remember pons. And when you remember pons, the rest you remember automatically. Pons, cerebellum, medulla. Okay, pons, cerebellum, medulla. Now, see, from rear rhombencephalon, we have meten and myelencephalon. From metencephalon, we have pons, and cerebellum. And from myelin, we have medulla. Just remember this. Now, they don't ask these questions much, but now they ask question every year from obstruction. They ask question every year from obstruction. Okay, every year from obstruction. Very simple. I will be keeping these for your seeing. Let me tell you what happens. Just see. They don't give CT in exam. Just see. Just to make your concept very clear, I gave these things. Now we have two lateral ventricles, right? Two lateral ventricles connected with interventricular foramen with third ventricle. Third ventricle. One, two. So this will be three. Third ventricle. This is our interventricular foramen. Interventricular foramen. From third ventricle, CSF will go through cerebral aqueduct. Cerebral aqueduct alone to fourth ventricle. So first we have two foramens, then we have one. That is in Bangla eka. So aqueduct or alone. So then we have fourth ventricle. Then we have on both sides of fourth ventricle, lateral sides, we have foramina lashka. On medial side, we have foramen magendi. Foramen magendi. Okay. And then we have central canal. Central canal. Okay. Then we have central canal and spinal cord. Around that, we have spinal cord. Simple and easy. So this is the serial. Now, do we have a view from side? No. If there is any obstruction, let's say we have an obstruction here. So what will happen? CSF will be trapped here and this ventricle will be dilated. So if they give you a picture like this, see, oh my God, this is very much dilated. So if they give you picture like this, lateral ventricles, only lateral ventricles are dilated. They will not give you picture. I'm just saying. So if they give you, if they tell you that a CT was done and this ventricle is dilated, they will just ask a simple question: where is the obstruction? Where is the obstruction? Simple as that. Here is the obstruction. Where? Here is the obstruction. If this ventricle is dilated, obstruction is here. Obstruction is in this is if this is right side, if this is left side, left interventricular foramina. Now, if three ventricles are dilated, now simple question goes for you. Which will you write in our chat box? Simple question. I will check later on. If 1, 2, 3 all are dilated, where is the obstruction? Fourth is okay. Fourth has no dilatation. If 1, 2, and 3, these three are dilated, where is the obstruction? Where is the obstruction? So this is obstructing hydrocephalus. Hydrocephalus. This is obstructing hydrocephalus. Do you need to know more? No. Now, in case of non-obstructing hydrocephalus, what happens? We have here a very big cistern. We have a cistern means just open space or empty space to carry or to hold CSF. Open space or empty space to hold CSF. Just some open space. Okay. So if there is an abnormal connection between fourth ventricle and this is the most common one, then we have this is the biggest one. We call it cisterna magna. Cerebellopontine cistern because here is pons and here is our cerebellum. This is our cerebellum. This is our pons. Okay. So here we have our cerebellopontine empty space or cerebellopontine cistern. which is connected through these three foramens. Which three? The one I told you, laterally, Lashka, medially, Magendie from fourth ventricle. Okay. So if these cisterns gets dilated, that means there is an abnormal connection between fourth ventricle and cisterna magna. Cisterna magna. So there is no obstruction, not in foramen, not in this foramen, not in this foramen. Just there is abnormal connection increased here. So CSF goes here. It could not drain appropriately. So this gets enlarged. That is called mega cisterna magna. So if there is an abnormal connection, just point to be noted. I if you just point to be noted, we will give specific question, and in your exam only that question will come if they ask anything about cisterna magna. You will face this question later on, not so important. So from first page, this thing. Then about foramen. Guys, see what are the most important foramen. I have told you. From above, two foramen. From below, two foramen. Why? First thing you need to know, from above, two foramen. From below, two foramen. What are the foramens? Number one, optic canal and superior orbital fissure. Why? Remember, what did we started from our childhood? Serially, we memorized all the cranial nerves, right? Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, auditory, like that, right? So remember, we get confused. Olfactory, optic, oculomotor, trochlear, trigeminal, abducens. From trigeminal only, V1. See, all of these serially, 3, 4, 5, 6. All of these will go through superior orbital fissure plus vein. I know. But in exam, during stress, we forget that number 2 have its own canal, optic canal. Number 2 does not go through superior orbital fissure. Superior orbital fissure, in short, SOF. Remember SOF, 111, that is 3. It starts from 3. It will start from 3. Oculomotor, trochlear, trigeminal, abducens. Oculomotor, trochlear, trigeminal, abducens. It will start from 3. Okay. And optic has its own canal, that is called optic canal. And they will give you simply this choice, that optic, oculomotor, where is it? Oculomotor, V1 of trigeminal, all these three. Lacrimal, frontal, nasociliary. Okay. Trochlear, abducens. Okay. 3, 4, 5, 1 ophthalmic branch of trigeminal nerve, and 6. And 2 has its own canal, optic nerve, ophthalmic artery. You first remember this one because these are confusing. They give you this question most commonly. Then behind happens the same. We have studied all our life serially: glossopharyngeal, vagus, spinal accessory, and hypoglossal. They will give you this question: which nerve does not pass through jugular foramen? And hypoglossal would be the answer because hypoglossal has its own hypoglossal canal. And in your exam, we just cannot remember. That's why these two are very tough to answer, and they give you this question. Glossopharyngeal, vagus, accessory, and hypoglossal has its own hypoglossal canal. And other things: internal jugular vein, inferior petrosal sinus, posterior meningeal artery, not so important. Just remember the veins. They don't bother about the arteries much. Then what do we have? Here we have optic canal. Here we have superior orbital fissure. After that, promax, foramen rotundum. Now come here. Promax, what is your payment method for? I was very poor. I'm still poor, by the way. Don't worry. To buy 14 Pro Max, and the payment method should have been kidney. Okay, so That's how selected a payment method. This meme was very famous back then when I first made the note, and I have kept it throughout still now because this makes me easy to remember. Foramen, rotundum, maxillary nerve, 14 pro max. Simple. Foramen, protundum. I used to say protundum because I don't have to say it. I just have to recognize. It's an SBA exam. It will be written. Okay. So then about ovale, otic ganglion, mandibular nerve, accessory meningeal artery, lesser petrosal nerve, emissary vein. Simple as that. OVALE. V3 mandibular division of trigeminal nerve. Spinosum. Remember, remember when someone hits you from lateral side of head, when someone hits you from lateral side of head, your head will spin. So remember, foramen spinosum. Spinosum is from, and it's related to middle meningeal artery. So you will have questions like someone got hit at the side of head. Which artery is most likely to be injured? Middle meningeal artery. What kind of hematoma will happen? Extradural hematoma, because middle meningeal artery is supplies meninges. So this is the skull and this is the brain, and middle meningeal artery is in between. So if it gets ruptured, it will push the brain. It will push the brain, and what will happen, I will tell you later. We have a surgery section for that. Then what are the foramens you need to know? So we have talked about foramen ovale, and then we have foramen other things, hiatus, lesser petrosal nerve, no, not important. Foramen spinosum, middle meningeal artery, you know it, and this is coming from carotid canal, internal carotid artery. Then we have this thing. Then we have this thing, that is our internal auditory meatus or internal auditory canal. Internal auditory canal in petrous part of temporal bone. See it very carefully. This is our internal auditory meatus. Our facial nerve will enter into inner ear. Inner ear, remember it. We have to see it very carefully. Now then, this is our jugular foramen. This is our jugular foramen, which will transmit 9, 10, 11. This is our hypoglossal canal. Okay, 9, 10, 11. And foramen magnum, everyone knows. But still, this is our spinal cord. Then we have anterior spinal artery. Then we have two vertebral artery. Depending on, then we two vertebral artery. Then we might have basilar artery. So don't worry, they don't ask. And we have, of course, accessory nerve, anterior spinal artery, vertebral artery, accessory nerve, of course, spinal cord, posterior spinal artery, spinal vein. They don't ask contents of foramen magnum. They don't ask. Give a reading to jugular foramen, internal jugular vein, accessory nerve, glossopharyngeal vagus, and posterior meningeal artery, inferior petrosal sinus. So all the nerves are done. Here is a chart. We have some nerves. You don't nothing. Just remember the location. Just remember the location. Just remember the location. Then nerves passing through superior orbital fissure, I have already told you. You will just write down serially. Superior orbital fissure, SOF. Write down serially from 3, 4, 5, 1, and 6. And remember, in front of it, we have cavernous sinus or behind. Just remember around it, cavernous sinus. Behind, we have cavernous sinus. And what happens? All these passes through cavernous sinus. All these with an extra V2. So we have cavernous sinus, then we have superior orbital fissure. Okay, so 3, 4, 5, 1, 5, 2, and 6 will come through cavernous sinus. Now this 5, 2 will go mandibular division of trigeminal nerve, go through some other foramen. Okay, and sorry, V2 maxillary division of trigeminal nerve. Sorry, maxillary. Maxillary will go through some other foramen, and all these will head towards superior orbital fissure. So now you know contents of two places, cavernous sinus and superior orbital fissure. Simple. Not important, give a reading. Just give a reading. Now, parasympathetic ganglion, you will be knowing after I take the class. Don't worry about it. Now, olfactory nerve CN1, nothing to study from here. Nothing to study from here. Just remember what I wrote it down. Goes through cribriform plate of ethmoid bone. Common cause of injury will be base of the skull fracture. They will tell you what are the signs of base of the skull fracture. Remember, this is our eye. And remember Kung Fu Panda. Kung Fu Panda like eye. This is called raccoon eye. Raccoon eye. So this will be a sign of base of the skull fracture. CSF leak will be a sign of base of the skull fracture. Then bluish or blackish area behind ear. That is battle sign. Battle sign. So all of these are base of the skull fracture signs. Simple. Base of the skull fracture signs. And they just give you one question from olfactory nerve that someone is having anosmia after a base of the skull fracture. Now, which part of skull is injured? Cribriform plate of ethmoid bone. Simple and easy answer. I'm telling you all the questions that can come to your exam. So note it down. Cribriform plate of ethmoid bone. Ethmoid. This is the specific question they will ask. Then about optic nerve, they will ask you only homonymous hemianopia. Only homonymous hemianopia. Remember, optic nerve goes through optic canal, ophthalmic artery, and sympathetic nerve fibers. Now, see, let me tell you the things. There are a lot of things I have written down. Now, do you need to know light reflex, accommodation reflex? No, they don't ask any question, but we have a video about it. Now, about what happens in our, let me show you. Let's say this is our right eye. This is our left eye. Okay. Now, this is our right visual field. This is our left visual field. This is our right side of our right eye. This is our left side of our right eye. This is our right side of our left eye. This is our left side of our left eye. Simple. Simple. So the light coming through this area will go here. Okay. And the light coming through this area will go here. Okay. Now the light coming from this area will go here. The light coming from this area will go here. Simple. Now, what about our optic nerve? See, this is our optic nerve, one in medial side and one in lateral side. The let's say outside. So outside. The outside one will come up to chiasma, then go to our Edinger-Westphal nucleus, and then become our radiation. So this is our optic nerve. This is our optic chiasma. This is our optic tract. And then we have optic radiation. Okay. Now, the one that is in medial side, it will go to opposite side. Opposite side nucleus. And then it will go to radiation. Optic radiation. See, radiation is like a lot of loops, different loops, a lot of name. Okay. Now, let's say due to some reason, due to some reason, we have, we cannot see this part of our, okay, let's see from this, this, just drawing it again. And uh, I need another color for it, guys. See. Okay. So from left eye, the medial side of optic nerve will cross and go to opposite side. Okay. And the outer side the outer side will cross and go to this side. Okay. So let's say we cannot see right side of our right eye and left side of our left eye. Okay. 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 No. Just. Okay. First, we just see this one. Right side, left side, right side, left side. Okay, guys. Just. I'm just trying to make it easy. Give me some time. Okay. Now, let's say we cannot see. We have an injury here. Let's say we have an injury here. This is number one. Let's say we have an injury here. This is number two. Or let's say we have an injury here. This is number three. Okay. Or let's say, and we will see it later on. Okay. Now, in case of number one, see, we eliminate, we eliminate all other tracts which are not involved. This is our optic chiasma. So we have an injury in optic chiasma. So the good ones, I am rubbing it off. The good ones. So the good ones, I am rubbing it off. Only the fibers that are defected are here. So we connect it opposite. So we have an injury here. So which side we will not be able to see? See, we go up, 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 and we see that we cannot see right side of our right eye. And if we go up, 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 we can see that we cannot see left side of our left eye. Right? If the injury is here, we see that we cannot see this side, left side of our left eye, and right side of our right eye. 1 minute, guys. So what happens? See, that's what they interpret as. So this is outer side. Outer side is called temporal side, and this is inside. It is called nasal side. This is temporal side. This is nasal side. So temporal, nasal, temporal, nasal. Now, what are we having? We cannot see this side of our right eye. This side is our temporal side. So this side is anopic. We cannot see. So this is not full anopic. We still can see half of it. So this side is hemianopic. Hemi, we cannot see half of it but half of the right side we can still see. So this is a hemianopia. We can see half of it. Okay, this is a hemianopia. Now, what kind of hemianopia? We cannot see temporal side of right eye and we cannot see temporal side of left eye. So two temporal hemianopia. This is two temporal hemianopia. This is called two means bitemporal hemianopia. So bitemporal hemianopia we will have only in case of optic chiasma compression by pituitary tumor or pituitary nerve. If there is any pituitary nerve, it will compress optic chiasma, which we have seen, and the fiber that are crossing that will get injured. This is number one. Now let's say number two. Let's say we have a lesion in optic tract. We have a damaged optic tract. Now we connect to where the fibers are going. Okay. So now we will be using blue color for it, right? Okay. So we will be using, so optic tract. Let's say here is the injury. So no light will be going through this area. So for which light we are losing it? So this red one, let's connect this red one and we can go up, up, up. and we can see that it's going to right eye like this. And which side this time? Okay, I'm erasing it, then again drawing it to make it simple for you. And watch it once and you will never get confused with hemianopias. Okay, let's draw it full. Again, this is our right eye, this is our left eye. Now we have fibers coming from this side and it's going to same side from outside or temporal region, temporal fibers, and nasal fibers like this, they are crossing. Okay, they are crossing to opposite side. And then again on this side we have this, from outside it's going to outside. Okay, and from inside it will be crossing to opposite side. It will be crossing to opposite side. Simple. Now this is our right side of right eye, left side of left eye. This is our right side of right eye. Sorry guys. This is our right eye, right side, left side. This is our left eye, right side, left side. Now thing is that light will be coming from this side to this side and this side to this side. Light will be coming from this side to this side and this side to this side. Let's say due to some reason I have a block here or damage here. Now what will happen? Let's follow the fibers. Stay with me. So this fiber is damaged and this will not take any information in. This will not make any image. Okay, so we cannot see with these fibers. So we go up, go up. Where is it going? Where is it going? Where is it going? So it's going to this side. So this side is damaged, so we cannot see left side of our left eye. We cannot see left side of our left eye. Then again we trace the opposite fiber. Trace the opposite fiber now. This one, this one. We trace the opposite fiber now. So this is going to, let me change the color a little bit, so to purple. So we change. So see, this is, where is it going? Where is it going? Where is it going? This is going to this side. So we are not having light from here. So we cannot see, this side is damaged. So we cannot see left side of our right eye. So what's happening? We have lost left side of our right eye. We have lost left side of our left eye. Okay, so how do they picture it? This one. So left side of our left eye is gone. Left side of our left eye and right eye both is gone. And these two picture are same. Same means homo. Same means homo. Man marrying man. Homo. Woman marrying woman. Homo. So we are not against that. I'm just not going to talk about that. If you are going to UK, you cannot judge people. So just to study. So same means homo. Same means homo. Looking same. Homonymous. Homonymous. Looking same. So these look same. Left side of both eye is gone. Left side of both eye is gone. So this is homonymous and this is anopia. We cannot see. Can not see. So this is anopia. This is anopia. Full anopia. No, because we can still see half. We can still see half. So this is hemianopia. Hemianopia. So this is our homonymous hemianopia. This is our homonymous hemianopia, which can cause if our optic tract is damaged, and optic tract is in parietal lobe. Parietal then spans across temporal. Okay, now then we have Edinger-Westphal nucleus, and then we have optic radiation. So if same thing happens, all the optic radiation is damaged, then only then we can have homonymous hemianopia. Also homonymous hemianopia. But if optic radiation has a lot of radiation, it's a radiation band, it's a band of loops. If they mention only one loop, the specific loop, let's say Mayer's loop of optic radiation is damaged. We will have homonymous hemianopia? No, we will not have homonymous hemianopia in case of one loop damage. Specific name. They will just ask when we will get homonymous hemianopia, and we are very clear about it that if optic tract is damaged, only and only then we can have homonymous hemianopia, that is looking same anopia, the anopia that looks same, that is homonymous hemianopia. And if we have a lesion in optic chiasma, we will have both temporal side damaged, that is called bitemporal hemianopia. Guys, if you watch this portion again, you will be very clear and you will not make a mistake with it in your life. Okay, then again, now they give interesting question in your exam. So they will just ask you homonymous hemianopia. Where is the lesion? Where is the lesion? Optic tract or whole optic radiation? Opposite sided. Okay, opposite side. Oh, guys. Okay, let's just show you the side. I have. Okay, now we have it. Now we have it. See. So why opposite sided? See, where we can't see which side we lost, left side of both eye. We lost left side of both eye. We lost left side of both eye, right? But see, which side was it? Right side. Which side was it? Right side, because this was our right eye and this was our left eye. So this was your left side, right? Which side was it? And so that means we have a right optic tract lesion, right? And we have lost left side of both eye. Simple and easy. That means this will be called left homonymous hemianopia. And we have lost right side of optic tract. Right sided optic tract we have lost. Now, they give you very, very beautiful questions. I'll be talking about it. So these are do you need to memorize it? No. That's why our classes are big. I explain things to make it very clear so you can remember these things easily. So homonymous hemianopia, optic tract, whole optic radiation, it's opposite sided. Homonymous quadrantopia is nothing. It's just half of it. Half, like one fourth. One fourth is gone. One fourth is gone. Just remember PITS. That is parietal lesion, inferior homonymous quadrantopia. They will give you direct question that inferior homonymous quadrantopia, where is the lesion? Parietal. Superior, temporal. PITS, temporal superior, simple as that. And where is the lesion? Optic radiation. Parietal tumor, superior branch of middle cerebral artery occlusion, you don't need that. Just remember parietal tumor. Just remember parietal tumor. And here just remember temporal tumor. Okay. And then bitemporal hemianopia, always optic chiasma compression by pituitary gland tumor or craniopharyngioma. Craniopharyngioma from above, pituitary tumor from below. Simple, one of it. Now see, they give you this question in a very beautiful way. Like they will tell you that a person is having his ring doesn't fit anymore. Ring doesn't fit anymore. Ring doesn't fit anymore. So what else you will check? What optic or visual problem he might have. What visual problem he might have. Guys, neuroanatomy class is big, so anatomy classes are big. You need to give a lot of time anyway, but you will not feel bored. Don't worry. You can feel bored, but I don't care about that anyway. Forgive me. Okay. So, uh, ring doesn't fit anymore. What does it mean? It means acromegaly. Shoe doesn't fit anymore. What does it mean? Acromegaly. And they will tell you another thing, tall. What does it mean? Anytime in MRCS part A, they tell you tall, it's Marfan syndrome. Always Marfan syndrome, unusually tall. Marfan syndrome. Why? What happens? See, our pituitary, what do we have? Our pituitary have anterior pituitary AP, posterior pituitary PP, which works on PP, that is ADH, which works on our PP. We will talk about that later. But in AP, we have a lot of cells like growth hormone, releasing hormone comes here, and it releases growth hormone. Then thyrotropin releasing hormone comes here, then it secretes thyroid stimulating hormone. Then we have gonadotropin releasing hormone, and it secretes FSH and LH. Do you need it now? No, you don't need it now. You will need it later. Then this growth hormone secreting hormone, what does it do? It grows you. Simple as that. How does it grows you? How does it grow you? Our bones have epiphysis, metaphysis, and in between, uh, in epiphysis, metaphysis, diaphysis, of course, we have growth plate. We have growth plate. This growth hormone will stimulate. And what kind of collagen we have here? Stimulate. So bones, remember BO1E, we have collagen 1 here. Simple as that. Cartilage, cartilage, collagen type 2. Collagen type 3, we have it in skin and other areas. Collagen type 4, from 4, remember fence is the cell basement membrane, cell boundary, cell basement membrane. We have collagen type 4. Now, what happens? Growth hormone will stimulate growth plate simply. Now, when it's before puberty, you have excessive growth hormone. This growth plate will grow a lot. Now, this growth plate will grow a lot, and his bones will be very, very big. But remember, when you have a factory, if you are Ananta Jolil, you know that I have a factory, I have 100 workers, they make 100 t-shirts a day, but I need more profit. So I will tell my 100 worker to make 1000 t-shirts a day. Will those t-shirts be quality full? No, right? There will be malformed t-shirts, so there will be malformed cells, there will be weak bones, collagen, connective tissue. Okay, so collagen. And what do we else have? Elastin, right? And others too, but just the ones that are important for exam. Remember, I will tell you all these things throughout the course, so you will not forget it. So growth hormone will stimulate the bones to grow a lot. It will grow a lot, and that person will be unusually tall. And where else will we have problem? See, this is collagen. So vascular in large vessels. In large vessels, what other connective tissues we have? Remember, in large vessels inside, that is intimate to blood, that is intima. In the middle, we have media, and in outside, we have adventitia. Now, in the media, we have elastic fibers. Elastic fiber. What does collagen do? Collagen gives tensile strength, tensile strength, and elastin gives elastic strength. What is elastic strength? Elastic strength means if you push me, I will go back and come back again later. Okay, so flexibility. But with age, what happens? I will tell you. We have aneurysm video. Don't worry, I will not make this unusually long. This is important. You will remember it. See, so media. So if we have fibrillin gene here, we have fibrillin protein here. Okay, so now what happens when these proteins are defected? These vessel wall are weak. So this person, when his blood pressure raises a little bit more, he has a tear in intima because it doesn't have that strength to hold that pressure. right? It doesn't have that pressure, so they get aortic dissection. Aortic dissection very commonly, and this is called Marfan syndrome, where you will have defective collagen synthesis due to excessive growth hormone. So, excessive growth hormone before puberty will give rise to Ehlers-Danlos, another collagen vascular disease, Ehlers-Danlos and Marfan syndrome. And after puberty, what happens? The growth plates are fused. Growth plates are fused, so bone cannot grow in length. It will grow inside, just like we do. After 30, our belly just grows bigger and we don't get tall, right? Simple as that. So his bones will be thicker. That's why his engagement ring will not fit anymore and he will have increased shoe size. Okay. So that is called acromegaly. These are due to pituitary gland tumor, pituitary gland which is secreting excessive growth hormone. So before puberty, Ehlers-Danlos and Marfan's. After puberty, this thing, that is acromegaly. So they will tell you that a person is having acromegaly or unusually tall person, which visual effect he might have. Very simple. If we have pituitary tumor, we know what will happen. Write that down in our chat box. I will check who are giving answers. I will give you chocolates later on. Okay. Then here the things I have written, just give a reading. Nothing to memorize. Then oculomotor nerve. Guys, oculomotor nerve is my favorite nerve. I just love oculomotor nerve. I just love it. Okay, so there are reasons why. So oculomotor nerve is very beautiful, and we have to describe it. Otherwise, you will not remember all these things. In long term, you will forget what will happen if we have. What did I tell you? A posterior communicating orgasm. Oh, not orgasm. Sorry, Duro. Sorry, guys. So posterior communicating artery aneurysm. Aneurysm. Okay. Now what happens, guys? So that artery will compress our oculomotor nerve. I am taking a cross section. Oculomotor nerve has two types of fiber. One is parasympathetic fiber and another is motor fiber, because it's oculomotor which will supply to our eye muscles. That will cause eye movements. I will show you that. Now, what happens? His parasympathetic fibers are above, parasympathetic fibers are above. So when it's compressed from outside due to any reason, it can be raised ICP, it can be extradural hematoma compressing the brain. Remember, brain is a closed box, and if it's compressed, it cannot go anywhere, it will go down and it will have tentorial herniation. And under it, we have seen that oculomotor nerve is coming out under the brain. I'll show you again. Coming out from midbrain, right? Midbrain, under the brain. So it will get compressed from above. So from anywhere due to raised ICP or due to EDH, if oculomotor nerve gets compressed, first thing that will happen, this parasympathetic fiber will get damaged. Get damaged. So what does parasympathetic fibers do? See, para, we have a term in Bangladesh, that is para, that is irritating someone. So if you irritate someone, what will happen? He will constrict himself from you. He will not come near you. So this is like para. So if you beat that person, what will happen? He will keep safe distance and he will get constricted. So parasympathetic nerve will cause constriction of the pupil. Just remember this. They will just ask you this. See, ciliary ganglion, from ciliary ganglion, we have short ciliary nerve that supplies the constrictor pupillae and constricts the pupil. Not important. They don't ask. Don't worry about it. Just remember, Edinger-Westphal nucleus is a parasympathetic nucleus. Okay. Edinger-Westphal nucleus. Edinger-Westphal nucleus is a parasympathetic nucleus. We have written it down. Don't worry. Parasympathetic nucleus. So ciliary ganglion is a parasympathetic ganglion. Remember these points, the things I tell you. Other things not important. Okay, and what is sympathetic? The one that shows you sympathy, the one that loves you, like Shah Rukh Khan, 6 feet, 6 feet distance in COVID, the signature pose, dilated hands, simple as that. Sympathy, love, that is called, that will, like, if someone says I like you very much, this thing, that thing, so I will open up to him, right? I will open up, I will talk, I will share my thoughts, I will take him to gym, I will make friends with him. Okay, so uh, so this thing happens, you dilate when someone sympathizes with you. So that happens. Then in case of dilatation, it comes from long ciliary nerve. Long ciliary nerve from C8T1. This is the sympathetic ganglion, which is called stellate ganglion. Sympathetic fibers comes from here, and long ciliary nerve comes along our internal carotid artery and gives supply to dilator or radial pupillae. That is called dilatation of the pupil. So they will just ask that which one causes dilatation, which one causes constriction. Parasympathetic causes constriction, sympathetic causes dilatation, and there is a balance always. Now, due to any reason, raised ICP or EDH, if these parasympathetic fibers are damaged, what will happen? This will be working without any opposition. Without any opposition, just like BNP is doing now. Okay, without any opposition. So, unopposed, unopposed action of sympathetic nervous system will cause dilatation of the pupil. Now, this dilatation can be constricted? No. So it will be fixed. So fixed dilated pupil. So anytime you see a fixed dilated pupil, what is that? That is para. Remember these statements. These I have chosen my words in our book very specifically. Like what did I do? We made a note, then we analyze the questions, and the words they used in questions, we used them, we replaced those in our book. We used those words. So when you go to exam hall, you feel familiar. Okay. So fixed dilated pupil, anytime you see it, it's a parasympathetic fibers damaged of nerve number 3. Okay. Number 2, unopposed sympathetic action. Unopposed sympathetic action. Which side? Same side. Why do you do operation? Same side. Bar hole, if you do it. Why? Because what did I tell you? Brain is a closed box. So if there is a middle meningeal artery injury, we have EDHC, everything is connected. That will compress the brain, and brain will go down. We have two oculomotor, two sides. Then what will happen? This side is pressed. So this oculomotor will get damaged first. So we will have dilated pupil on the same side, dilated pupil, and we do bar hole at same side. Right sided fixed dilated pupil, right sided bar hole. Simple. Now, these things just give a reading, not important, nothing to memorize. Now, let's come to oculomotor nerve compression. You already know it. Give a reading, nothing to memorize. Whatever I told you, important. Just give a reading, not important. Just remember aneurysm of posterior communicating artery and posterior cerebral artery and raised ICP. Just to help you. No direct question comes from here. And oculomotor nerve injury, what will happen? See, squint. These are not really important. I will tell you, don't worry. Dilatation of pupil, just give a reading. Loss of accommodation in right reflex, you know. Diplopia, double vision, you know. Then ptosis. What is ptosis? Actually, uh, levator palpebris superioris, LPS, has both sympathetic and parasympathetic supply. So even if there is sympathetic damage, your drooling of uh, eyelid. Okay, this is ptosis. So like the one that takes marijuana, you know, their eyes, that is ptosis. Okay, so any fiber, either sympathetic or parasympathetic, you will have ptosis. So if stellate ganglion is damaged, that is sympathetic fibers are damaged, you will have ptosis. And with ptosis, if you have meiosis, that's unopposed parasympathetic action, right? That means sympathetic fiber damaged, sympathetic damaged. If with ptosis you have Dilatation of pupil or mydriasis, that is unopposed sympathetic action. That is parasympathetic fibers are damaged. Fibers damaged. Okay, these are very frequent question in exam. Very frequent question in exam. Now, then about eye movement, guys. Then about eye movement. About eye movement. See, about eye movement, we have very simple and easy. Very simple and easy. Okay, so medial rectus. So which one you will be needing? I'm just telling you. So write this I and draw this. Simple as that. Remember SOD. From from childhood we have studied SO4 LR6, but instead of 4 I write D. Why? A B C D. D is the fourth word. Simple as that. So what's wrong with writing it? So SOD. SOD means superior oblique will pull the eye downwards laterally. Laterally, and D is the fourth word, will be supplied by trochlear nerve. Trochlear nerve. So superior oblique will pull the eye SOD downwards laterally. Downwards laterally. And lateral rectus LR, we all know 6. Lateral rectus will pull the eye laterally. Now, if lateral rectus is damaged, what will happen? Eyeball will go to opposite side. Simple. Person cannot look lateral side. Okay. And if superior oblique is damaged, what will happen? Eyeball will drift upwards because opposite muscle will be taking full control, that is inferior oblique, pulling the eye upwards laterally. Upwards laterally. So if superior oblique is damaged or fourth nerve is damaged, eye will drift upwards. Person cannot read books because superior oblique is the primary muscle for reading books. Person cannot look downwards laterally. And where will be the eyeball? Eyeball will be at this side here. And eyeball will be here in case of lateral rectus damaged. Okay, in case of lateral rectus damage. Simple as that. Just need to know, you just need to know these things. Other things, just give a reading. Guys, give me a minute. I'm taking a short break. Coming again soon. Okay, guys, I'm back. I'm sorry for the inconvenience. It's just I have a little 1-year-old boy, and he just keeps calling me all day, Papa, Papa, Papa. So I have to check on him a little bit. Anyway, so then, where we were at C. Now, let's say we have a damage to our lateral rectus. Lateral rectus. Now what will happen, this eyeball will be here. If you if they give you a picture, they will give you a picture like this, and anytime you see a picture like this, you remember our Ilish maths, and that's a lateral rectus palsy. And what will happen, so this eye will make image here, this eye will make image here, so you will see two objects, that is called diplopia or double vision. Now, these are laterally. So these objects are made laterally. That's why this is called lateral diplopia or horizontal diplopia, nothing else. Simple and easy term. Horizontal diplopia. Now, if you have a paralysis of superior oblique, let's say superior oblique is paralyzed on this side, so this eye will be here, this eye will be here. So when I will be standing here, you will see I will be standing here with this eye, and with this eye you will say I will be standing another me above myself. So vertically to Dr. Khan you will be seeing from epiglottis. Anyway, so vertically to me you will see, and this is called vertical diplopia. Simple. Vertical to Dr. Khan's vertical diplopia. Simple. So this is vertical diplopia. So if you have a paralysis of lateral rectus, you will get, why am I telling only these two? Because they will give you only these two. And if oculomotor is paralyzed, what will happen? What will happen? All your muscles are paralyzed except superior oblique. Superior oblique. Let's say this side oculomotor is paralyzed except superior oblique and lateral rectus. So eyeball will be pulled here. Eyeball will be pulled here. So oculomotor is paralyzed and superior oblique will pull it downwards too. So eyeball in case of oculomotor paralysis will be at this corner, which will be at this corner. So these are three things you need to know. Nothing else needed. Nothing else needed. Just these three. Then oculomotor nerve, where is the nucleus? Midbrain. You have to know. Trochlear nerve, CNIV. Where is the nucleus? C. Midbrain. Simple. You need to know. They will ask you where is the nerve nucleus of oculomotor nerve. Abducens nerve, you all know. Mid pons at pontomedullary junction. Pontomedullary junction. What did I see? Pontomedullary junction 6, 7, and 8. Okay. Then these things not important, not important. Just remember where is the nucleus. Then head trauma is the commonest cause. Remember, head trauma is the commonest cause of acute fourth nerve palsy, and most common nerve damaged in raised ICP is abducens. Abducens, nerve number 6. See, these two questions are different. You every year you people mix it, and I get mad. Don't do this, guys. What is the commonest cause of fourth nerve palsy? Head trauma. And which nerve gets injured first in head trauma or raised ICP? Abducens. Two different questions. Listen again if you don't understand it. Repeat it just 10 seconds. Best. You will understand it. Don't worry. And you know that what will happen in case of abducens palsy, lateral diplopia, just give a reading. They don't ask. Remember this. Diplopia and descending stairs. Just remember this one. They give you question. Are unable to look down and outwards. Outwards. Okay, then here are some key points. Here are some key points just to revise. So you memorize it all. Memorize the ones I have told you, described all along. All are here. All are here. All are here. So just remember it. And about corneal direct light reflex lost, consensual light reflex present. Just just a complex thing, not important. They don't give in exam. If you don't want, you don't need to study it. You can watch a short video about light reflex. Not important, not important, not important. There are a lot of things to study and much more important than this. And corneal reflex is more important than it. Corneal, what's in a corneal reflex? Let me just briefly explain it, because no one else in your life will explain these things to you. No one else in your life. And I don't know if in your medical colleges people have described it. You must have been forgotten. So this is the last time you are hearing it. So hear it, and you will not found proper videos on YouTube too. So what will happen? See, corneal reflex, cornea sensation. Who takes corneal sensation? Ophthalmic division of trigeminal nerve, right? Ophthalmic division of trigeminal nerve. This, if you touch one cornea, trigeminal nerve will take it in your brain. And what will happen? Brain will give motor fibers through facial nerve, where orbicularis oculi, which to zygomatic, start from above, temporal and zygomatic. These two will supply orbicularis oculi. So what will happen? When you touch one cornea, both eye will blink through facial nerve. So sensation comes through trigeminal and exits through facial. So comes or ascends, or afferent fibers are afferent arc of this reflex is trigeminal nerve, and efferent arc of this reflex is by facial nerve. Simple. Exit efferent, and ascent or afferent from trigeminal. Trigeminal takes, and facial exits. Very simple. Let's say this is our right eye, this is our left eye. You touch right eye and both eye blinks. That means it's normal, right? Now let's say you have problem in this input, or right sided trigeminal is damaged. Trigeminal damaged. So if you touch this eye this time, you touch, but this is damaged. So no impulse go in. No impulse go in. So what will happen? No blink. No blink. So no blink. No input, no output. Simple. No blink in both eye. No blink in any eye. That means bilateral absent blink. Bilateral absent blink. Simple. Bilateral absent blink. So if afferent arc is damaged, you will have bilateral absent blink. Now let's say this is okay. There is no problem with this. But facial nerve of any side, let's say this side is damaged. So input will go in, but during output, what will happen? You will have output here, but no output here. You touched right eye and you will input is okay. So you will have one blink only. One blink. Which one? The output that is okay. Output that is okay. If right eye output is okay, you will have blink in right eye. But if right eye output is damaged, you will have no blink in right eye. But you will have blink in left eye. Simple. So if afferent arc is damaged, afferent arc damaged, you will have bilateral absent blink. Absent blink. So let's say right eye, left eye. You touch right eye, no blink. But when you touch left eye, both will blink, right? So by touching both eye, you know that there is our right eye trigeminal damaged. Trigeminal damage. If efferent arc damaged, you will have one-sided blink, unilateral absent blink. Unilateral absent blink. You touch right eye. You touch right eye and right eye does not blink. Does not blink. But left eye blinks. That means the problem is in efferent arc. Efferent arc. And in which side? On our right sided facial nerve injury. Right sided facial nerve injury. Simple. So beautiful, right? So beautiful. And if left eye doesn't blink, then we have left sided facial nerve injury. Then questions just to practice. You revise it. You just give a reading. Abducens nerve questions, give a reading. They don't ask much question from here. And we will, you will not have much question. Give revise during. Later on, we will understand. Now, trigeminal nerve, very important nerve. Very important nerve. They will ask you just specific place and their supply. Specific place and their supply. Okay. Now you have to know that it has three divisions and which foramen they comes out. We all know that ophthalmic comes from SOF, maxillary from Promax, and mandibular, of course, ovale V3. Simple. And three nuclei. Where are these three nuclei situated? You have to know. Midbrain, pons, medulla, spinal nuclei. Okay. And names of these three nuclei. You must know it. Give a reading to these. Nothing comes from this area. Just give a reading. Not important at all. Not important at all. Here, just see the picture. Nothing important. What are important? I'm telling you. These branches. Name of the branches and where they supply: frontal, nasociliary, lacrimal, upper eyelid and conjunctiva, upper eyelid and forehead, supraorbital, supratrochlear, not important. Just innervation, this one. Lacrimal, nothing important from here. Just remember lacrimal gland. Lacrimal gland. And nasociliary, of course, from nasociliary you need to know that anterior ethmoidal nerve that supplies tip of nose and the bridge of nose, the prominent area of nose, the bridge of nose. They just ask nerve supply. They just ask nerve supply. Here is the photo. Here is the photo. You have it here. Give a reading. Nothing is important here. Give a reading. Just the thing I mentioned, memorize those like three branches name, axillary frontal lacrimal, exits through where. Then these 200% important. Memorize it. These 200% important. And just see this picture, the one I have shown you in our model. That's just here. External nasal branch of anterior ethmoidal nerve supplies the tip of nose. We have a chart, don't worry. Then maxillary branch. Just give a reading and memorize these two, purely sensory and leaves to for cavity. Others just give a reading, nothing important. And remember the supply. Infraorbital nerve comes through infraorbital foramen. So it supplies the cheek. If there is. So where does it supply? You know it. Ala of the nose, cheek, upper lip. What are the questions they will ask? They will ask you that a person is having upper lip numbness. Upper lip numbness. Which nerve is injured? Of course, superior dura. Infraorbital nerve. Infraorbital nerve. Okay, they will tell you that cheek numb. Cheek is numb, so infraorbital nerve. And teeth, upper teeth, if they talk about upper teeth, of course, superior alveolar nerve. Superior alveolar nerve. Simple. Simple. Just remember these three. Just remember these three. Okay. Branches of maxillary nerve, not important. Not important at all. Just the ones I have told you. Just remember these questions, 100% important. 100%. Just give a reading to these things. Mandibular division of trigeminal nerve. Mandibular division of trigeminal nerve, you need to know that it's mixed and it's a nerve of first pharyngeal arch. They will tell you that a person is having problem with masseter or cannot chew. So, which pharyngeal arch is involved? Remember first. Person is having, we will talk about those later on. Don't worry about it. Okay. So then, and remember it's mixed, and remember lingual nerve and inferior alveolar nerve. Lingual nerve, inferior alveolar nerve. And remember nerve to mylohyoid. Just know the names. Just know these things. Others not important. You need to know the names of muscles of mastication, all four muscles of mastication: masseter, temporalis, and medial and lateral pterygoid, and others. These are others. Others muscles of mastication supplied by, you must know. They will tell you that which muscle is not innervated by nerve of first pharyngeal arch, that is mandibular division of trigeminal nerve, and they will give you four options: masseter, temporalis, medial pterygoid, lateral pterygoid, and some other muscle. They will tell you maybe uh, stylohyoid, stylohyoid. Okay, they will tell you like this. And other things, give a reading, not important. Just give a reading. These are not important at all. Give a reading. But remember names of muscles of mastication. And then they will ask you nerve supply, the things I told you. This is our inferior alveolar nerve that's entering the mandible, coming out from mental foramen, and mental nerve giving lower lip sensation. Lower lip sensation. Lingual nerve giving sensation to touch, pain, temperature sensation to our tongue. Touch, pain, temperature. Touch, pain, temperature sensation to our anterior two-third of tongue. Anterior two-third of tongue. Lingual nerve from mandibular division of trigeminal nerve. You must know that lingual nerve wraps around submandibular duct. We will talk about that in head neck. And here are the pictures of which nerve supplies here. See this picture for better understanding. Then here's the summary. Here's the summary, and all the, these are the questions. These are questions they ask, direct questions. Which nerve supplies, and the options they gave in exam. The options they gave in exam. Okay, memorize it. 100% important page. And lateral surface and ear. Ear supply, 100% important. Lateral surface, medial surface, 100% important. But behind ear, here we have a picture. Behind ear means behind ear, not posterior surface of ear. Posterior surface of ear is supplied by greater auricular nerve, but behind ear supplied by lesser occipital nerve. Lesser occipital. Okay, this is our trigeminal nerve. Then lesions of trigeminal nerve, give a reading. Not so important. The ones I mentioned, only those remember, and others just give a reading. And here we have attached a corneal reflex photo. Don't worry about it. Just see it. Then facial nerve is the most important nerve from all cranial nerves. They give questions from facial nerve and trigeminal nerve every year. Like a lot of questions. And remember, facial nerve comes from pons. You must remember it. They ask you this question. These are not important. If you have time, give a reading. What is important? This one. This is important. Don't get confused. This is very easy. Let me just explain it you in 2 minutes, and you will be understanding everything. Remember every word I say. Every single damn word you must remember, or you will fail this exam. And no one else in your life will ever tell you like this. This is our superior salivatory nucleus and lacrimatory nucleus in brain. Remember the name: superior salivatory and lacrimatory nucleus. Salivatory, let's say, and half part of salivatory is lacrimatory. Lacrimatory. Okay. Then we have facial nerve proper, motor fibers. Motor fibers. Then we have taste fibers from tractus solitarius. You don't need that. Nucleus of tractus solitarius. Taste fiber. So these four fiber makes facial nerve. Okay. So salivatory fiber will come. Lacrimatory fiber will come. Motor fiber will come. Taste fiber will come. And this is called nervus intermedius. Nervus intermedius. That enters through internal acoustic meatus. Internal acoustic meatus. Then there's a turn. This is called geniculate ganglion. Though there is no ganglion or collection of cells, but there is no collection of cells here. Still, it's called ganglion. There's a turn. All of the fiber inside inner ear, inside middle ear cavity, they will take this turn. All of the fibers will take this turn except lacrimal fibers. So this is our geniculate ganglion, GG, geniculate ganglion. Lacrimal fibers will go straight, and its name would be greater petrosal because it's entering the petrous part of temporal bone. Now it's greater petrosal nerve. Greater petrosal nerve will go to our uh, pterygopalatine ganglion, which is the parasympathetic ganglion again. Pterygopalatine ganglion. Now, whenever someone goes, what do we do? Now, Terry is going. Terry is, let's say, we love Terry a lot, so we will cry. So, what will happen? Pterygopalatine ganglion. So, we will have lacrimal gland supply from this pterygopalatine ganglion. Lacrimal gland. Just remember what I say. Nerve name, only the names I mention. I specifically mention names. I skip other names because so you don't forget. So important ones gets to your brain first. Lacrimal gland and nasal mucosa. Nasal mucosa. So you will be secreting tears and plus nasal secretions when Terry goes. This is so lacrimal fiber will go straight, but all of these will enter inside middle ear cavity. Then these green fibers are motor fibers, but these blue fibers are taste fibers. Okay, motor fibers will go to facial muscles, but taste fibers, after going halfway, they realize where am I going? What is life? Why am I going? So they will take a turn. Taste fiber will take a turn behind tympanic membrane like a cord. That's why it's named chorda tympani. And along with that, salivatory fiber will think, oh my God, he is going, so I will go too. So they will go because their destination is at the tongue because they need taste. So where is taste? At the tongue. So they are going to the tongue and saliva, of course, where there is taste, there is saliva. So salivatory fibers will go with chorda tympani too. Behind tympanic membrane, that's why it's called chorda tympani, and they will go and along with that they will meet that L guy. L guy. Okay, so don't make it otherwise. L is good. Okay, like chorda tympani, that beautiful young chorda tympani, and two alone chorda tympani girls. Chorda tympani and salivatory fibers. So these are coming through petrotympanic fissure, and this one, this L guy, that is lingual, meets them and they takes them to their places. Like he likes beautiful young girls, that's why. So he needs some saliva too. He needs some taste. Okay. So and they work together. How? Anterior two-third of tongue. Lingual nerve will take touch pain temperature. Chorda tympani branch of facial nerve will take taste from anterior two-third of the tongue, and this one will go to submandibular ganglion. Submandibular ganglion. From submandibular ganglion, submandibular gland, and sublingual gland. They cause saliva secretion. Simple. And what happens to this motor guy? This motor guy goes out through stylomastoid foramen and gives anterior division, posterior division. And before that, it gives a little branch that is nerve to stylohyoid. Stylohyoid. And anterior division will give temporal and zygomatic, and these will give buccal, marginal mandibular, and cervical branch that will give facial expression. Facial expression. Simple. All these things I have told you right now is lower motor neuron, and upper motor neuron comes from cortex. Okay, and these all these are lower motor neurons. So this is the complete facial nerve. You must remember it all your life. All your life. Oh, I forgot one thing, that is motor branch gives one branch inside inner ear, that is nerve to middle ear, stapedius. Nerve to stapedius, that goes to stapedius muscle that tenses tympanic membrane so that it causes sound reduction. Sound reduction. So if someone listens to more sound, that means hyperacusis. If someone has hyperacusis, this nerve is damaged. And they give you these questions. They give you these questions. Give a reading to branches of facial nerve. Just give a reading, not important. You know, already know everything. This is 100% important. And remember, second, seventh, number of seventh arch. We have a pharyngeal arch pouch cleft video. Very beautiful video. You will be needing it. And now that's how they ask question. That's how they ask question, that where is the damage. How will they ask question? Just write, after you know all these things, just draw this one line. This is geniculate ganglion, before that lacrimal supply. Okay, this is stylomastoid foramen. Okay, and here all the motor supply, and this is inner ear or middle ear cavity. Middle ear cavity, this is nerve to stapedius. So they will tell you a person is having injury proximal to geniculate ganglion. Okay. So proximal to geniculate ganglion is here. So all will be lost. All lacrimation lost, hyperacusis will happen, and facial nerve will be paralyzed. And if they say that this is number one, let's say number two, distal to geniculate ganglion, inside inner ear, distal to GG, they will just ask which function will be preserved. So the injury is here, lacrimation is here. So this will be preserved, and hyperacusis will happen, then facial paralysis will happen. If they say injury is below stylomastoid foramen or distal to stylomastoid foramen, so what will happen? Only facial expression will go. Facial expression will go. Simple as that. Okay, so here we have made a chart that if lesion is at D, what will happen? Lost functions and preserved function. Lost function and preserved function. First, watch that thing very carefully. Then you study it. This is 100% important. All the lost functions are here. And they ask you a frequent question. Do you need to know details about it? No, you don't need to know details. All you need to know is how do you differentiate upper motor neuron lesion from lower motor neuron lesion in facial nerve. Remember, just ask the patient to raise eyebrow. Raise eyebrow. If eyebrow can be raised, then it's an upper motor neuron lesion of opposite side. Opposite. They will tell you that half, right half. Let's say this is right, this is left. They say left half of face is paralyzed. Under eye, below eye, left half of face below eye is paralyzed. So what will you do? You ask the patient to raise left eyebrow. If he can raise left eyebrow, then the lesion will be right sided upper motor neuron. The lesion will be in right sided upper motor neuron. Okay. So, and lower motor neuron, person cannot raise eyebrow. Just remember this line, what I said. Nothing else is needed. Raise eyebrow. Paralysis of total half of the face. Understand, whatever I have written is 100% important. You memorize it. You memorize it. Uneven smile, buccal or marginal mandibular nerve. Why? Why? Because buccal raises the corner of mouth, and marginal mandibular depresses the depressor anguli oris, depresses the corner of mouth. So if one is paralyzed, there will be imbalance in smile. Give a reading, not important. Glossopharyngeal nerve, nothing much to study from here, only the things I tell you, other things forget. Sensory supply, spatial sensory supply, parasympathetic supply, and motor supply. Guys, these are the things that are important. All you need to know that glossopharyngeal nerve is associated with third pharyngeal arch. Okay, third pharyngeal arch. Now, sensory supply innervates the oropharynx, and do you need to know it all? No. What are the things you need to know from sensory supply? You need to know that gag reflex, afferent arc is made by glossopharyngeal nerve, GP. We use GP sim for call. So GP will take sensation to brain. And where is its nucleus? In medulla. Remember it, they ask. And efferent arc, exit is by vagus. Okay. Vomit. You touch the patient at posterior one third of the tongue, and that person vomits with vagus. So the sensation is taken in by GP and exited by vagus through vomit. So efferent arc is found by vagus. They just ask you this question. And taste supply. Where does it supply? It does special sensory taste sensation to posterior one third of the tongue. You must know it. Parasympathetic supply. It provides parasympathetic innervation to parotid gland. How? Remember what I say. Remember what I say. And others just give a reading. Not important at all. Just give a reading. Just give a reading. Just give a reading. They don't ask any question. Any question. Give a reading. Just reading. Nothing comes in exam. Let me tell you what happens. Glossopharyngeal nerve will take parasympathetic fiber up to otic ganglion. Otic. And after otic ganglion, auriculotemporal will take this parasympathetic fiber to parotid gland. So remember questions. Number one, which ganglion is related to parotid gland? Otic ganglion. Number two, which one takes preganglionic? This is the ganglion. So this is before ganglion. So preganglionic parasympathetic fibers. Preganglionic parasympathetic fibers is taken by glossopharyngeal nerve. Which nerve takes postganglionic parasympathetic fibers? Auriculotemporal nerve. Remember all these. These are direct questions. If they ask you a question from here, they will give only these questions. I know it's hard to trust me, but this is the truth. Every year that happens. Now Vegas nerve, give a reading, not important. They don't ask anything. Give a reading, not important. In the head, nothing comes from here. Nothing comes from here. Give a reading. Give a reading. So you can correlate better during others. That's why you need to give a reading, but nothing to study. Nothing to study from here. No question comes. Initiation of swallowing, motor function, swallowing and function. Remember this and remember this line that larynx, it supplies innervation to larynx and recurrent laryngeal nerve and vagus nerve injury during thyroidectomy. We will talk about that in our head neck. Parasympathetic function reading. Nothing important. Hypoglossal nerve. You and answer cervical is give a reading. Nothing is important here. Just give a reading. Now you need to know hypoglossal nerve. Let me tell you what you need to know from hypoglossal nerve. See, hypoglossal nerve supplies all the extrinsic muscles of the tongue except palatoglossus, which is supplied by vagus. Okay. Now, the main bulk of our tongue is made by genioglossus. Genioglossus. This is our hypoglossal nerve. This is our hypoglossal nerve. This will supply genioglossus. This will supply genioglossus. What does genioglossus do? Genioglossus will protract the tongue, push the tongue straight outside. If you ask the patient to put his tongue out, genioglossus is the nerve muscle that is pushing the tongue out. Now, if hypoglossal is injured, you ask the patient to put the tongue out. This side genioglossus is okay, so this will push, but this side genioglossus is damaged, so this will not push. So what will happen? Your tongue will not go straight, it will go at this side because there is no push from this side. So this will indicate, this will direct where is the injury. So tongue deviated, let's say this is our right side, this is our left side. So tongue deviated to right side, that means right hypoglossal is injured. And what's the most common nerve that gets injured during carotid end arterectomy? Hypoglossal nerve number one. Carotid end arterectomy. Hypoglossal number one. Number two, vagus, because of their position. Okay, just give a reading, you will understand what am I saying. Spinal accessory nerve, just remember that winging of scapula. Winging of scapula. Winging of scapula. Remember, any this we will talk about that in head neck. We have talked about that in head neck. We will give the recorded class. Don't worry. Now, posterior triangle. Any procedure in posterior triangle. Then winging of scapula. Posterior triangle of neck. Winging of scapula. Spinal accessory nerve damaged. Any procedure in axilla. And then winging of scapula. That is serratus anterior damaged. Okay. This is spinal accessory. This is serratus anterior due to long thoracic nerve damaged. Long thoracic damaged. Okay. We have it in our head neck. Don't worry. Now, blood supply of the brain, whatever I have shown you in that picture, that will be enough. So remember from ICA that first branch after coming out from cavernous sinus is ophthalmic artery. Remember, it has no branches in neck. No branches in neck. Others, these are not important. They don't ask any question. Just remember what I said. Continuation and branch. These two lines. Remember continuation and branch. Continuation and branch. Then VIP scoma, if you want, you can study, but nothing comes from here. Not important at all. Anterocerebral artery. These are the strokes. What happens? Just remember what I say, and others not important because this is a surgery exam. They don't give you much complicated question from stroke. See, if legs are paralyzed, it's anterocerebral artery stroke. If hands are paralyzed or upper limb or dysphagia, middle cerebral artery stroke. If vision change, just remember these things and you will be able to answer any question from stroke. If vision change, posterior cerebral artery stroke. But remember, if dysphagia and upper limb paralysis plus vision change, that's MCS stroke. Just remember these three and you will be able to answer any stroke question, be it medicine or surgery. You will be able to answer it. And posterior inferior cerebellar artery infarct. Remember nystagmus, medullary syndrome. Just memorize this one. And others, just remember all those. Just see the picture. These are for saying nothing else. Which nerve will be affected first in case of anterior inferior cerebellar artery infarct? See, we have seen you and we have shown you anterior inferior cerebellar artery and posterior inferior cerebellar artery. Let me see. Let me see. Uh, Here is our anterior inferior cerebellar artery. Remember, abducens will be injured. Abducens. Abducens will be injured first, then facial, then vestibulocochlear. Okay. And posterior inferior cerebellar artery. Where is our posterior inferior cerebellar artery? So abducens will be first. Here you may we have a correction that anterior inferior cerebellar artery you will have abducens as first damaged. Other nerves, facial, glossopharyngeal, no, not so common. Don't worry about it. Which one of the form posterior boundary of circulopule is, posterior communicating artery? And what about posterior inferior cerebellar artery? I have shown you in our, this is our posterior inferior cerebellar artery. This is our posterior inferior cerebellar artery. If you have seen in our 3D model, that glossopharyngeal vagus, here we will have problem in glossopharyngeal, uh glossopharyngeal vagus, of course. Then just see, nothing important. Then cavernous sinus. See what I told you. Remember, these are your cranial nerve 3, 4, 5, and 5 and abducens is in the middle of cavernous sinus near internal cavity artery. I see. Remember this. that only abducens, now number 6, is inside the cavernous sinus and others are on lateral wall. So if there is cavernous sinus thrombosis, first affected nerve would be nerve number 6, that is abducens nerve. Remember this. Okay, and remember the contents the way I told you. Okay, and all these things. This is the danger area of face because face is drained by facial veins, which is valveless. Facial vein, which is valveless. So infection can spread to brain. Then dural venous sinus, just these three lines. Just these three lines, nothing else important. Just memorize these three lines. And circulation, you can study it later on, not needed in part 1, not needed in part 1 at all. Spinal nerve, you can just see this because no question comes. Just remember that dermatomes are different thing. When we complete all the anatomy, you will get all the dermatomes. These are just for seeing. These are just for seeing. Okay, then there are some things you need to know, that is the end of spinal cord, that is called conus medullaris. It is at L1 level in adult, and in child it can span from L2 to L3. Okay, it can go up to L3, up to L3. And this is our dural sac. Dural sac, it ends at S1 in case of adult, and in case of child S2. More common, S2 more common, but it can go up to S3 too. Okay, so remember, in case of conus medullaris at the end of spinal cord, adult always go for L1. Child, you will have either L2 or L3. Either one of them. Either one. Either L2 or either L3. If you have both, choose L3. Because this is a question of best answer. You have to choose the best one. And in case of dural venous sinus, dural sac, dural sac ends at S1 in case of adult. This is fixed. Okay, but it can. This is the most common, and S2 can be S3. Either one, you will have either one in options. If you have both, go for S2. S2 is more common in humans or in humans. Okay. So cauda equina syndrome, just give a reading. They don't ask any question from here. Okay, then vertebral body. Then vertebral body. Just remember that spinal cord, that intervertebral disc. That intervertebral disc consists of nucleus pulposus (NP) and annulus fibrosus. In case of a prolapse, P for prolapse. So nucleus pulposus will prolapse due to annulus fibrosus is deficient. Annulus fibrosus deficiency. So annulus fibrosus is deficient. With age, it becomes degenerated or deficient. That's why nucleus pulposus can prolapse. Okay. Then other things, nothing else are important. Remember, inside the dural sac, spinal cord is tied with denticulate ligament. Just remember this information. Others just see. Not important. That's how our neuroanatomy class 10 class ends. And remember, we will have head neck class after 3 days studying neuroanatomy. If you have any question, you ask me in question posting group. I will be answering. If I get late, don't worry. I will answer still. I will answer. And about classes, in 4 months batches, most of the classes are recorded from previous class. And I will the day I will take live class, I will let you know. My manager will let you know before the class, on the day of the class. And otherwise, we will just post recorded class and you just watch it. And I will ask people. We will take exams and we will ask, are you watching or are you having any problem? You will let me know. Thank you guys. Have a good night. And no one answered. Okay, I don't know. What are you people doing? Thank you. Anyway, thanks for joining.